Hello, Dr.
Hi, nice to meet everyone. Hi, Bosco. Hi, SwipeRx and iNova and all our dear pharmacists who joined today. I'm Dr. Sanjeev Rampal, and Bosco Mu has been nice enough to volunteer to moderate this session. And we'll be talking today a little bit about role of muscle relaxant in low back pain management, a short update, and what the role that we can do in dealing with the most common musculoskeletal presentation in modern clinical practice. So I'll let Mr. Bosco Mu, who's a pharmacist from Alpro, take over.
Can everyone see the slide? Yes, okay, then I will start now. So good afternoon, everyone. First of all, thank you, the iNova and SwipeRx for providing this opportunity for us to have this wonderful session. So just a little bit of webinar house rules. Please mute your microphones throughout the webinar and place your questions in the Q&A chat box. I'll be gladly raise them during the Q&A session. And to obtain a certificate and claim your CPD points, just remember to attend the sessions for at least 2 hours as your time is recorded. For any questions or concerns, please email us at swiperx@gmail.com and we will gladly assist you. So the first topic today is by Dr. Sanjeev. He'll be talking on the role of muscle relaxant for low back pain management. Dr. Sanjeev Rampal is a senior lecturer and also consultant orthopedic surgeon at University Putra Malaysia and Beacon Hospital. He obtained his MBBS degree in 2002 and began practicing at Ministry of Health of Malaysia in 2004. Dr. Sanjeev then pursued his specialization in orthopedic surgery at National University Malaysia, completing it in 2012. And then he further enhanced his expertise through fellowship in 2017 to 2018 in Europe, including France, Germany, and also Italy. So without further ado, let's welcome Dr. Sanjeev.
Well, thank you so much, Bosco, and thank you so much for the team, especially another shout out to iNova and SwipeRx for hosting me on this platform. I am truly privileged and honored to join you guys. And today I thought I'd give an update, or basically maybe give you all a short summary of how to deal with the most common complaint that in orthopedics practice in Malaysia and in the region and in the world about low back pain, and how we deal with low back pain, and how does a clinician use the medications that we are using to our advantage to deal with low back pain. Yeah, so I'm just going to start sharing my screen for the slides. So is it Bosco? Is the screen my slides or no?
I'll be happy to share your slide.
Okay, so I guess we can, yeah, you can go on to the first slide then.
Okay, just a moment.
So a little bit about what we're going to discuss today. So basically what I'm going to do is I'm going to give you all a summary of how we deal with the most common back pain, give you a little bit of summary about the common complaints that I get when the patient comes and sees me, and then a little background about how common the knee pain, back pain is, and what is the treatment that we are giving, and how does the role of antispasmodics comes in when we deal with low back pain, or including slip disc. Yeah. So the common complaints that I usually get is the first part of it is the common complaints. So the common complaints I usually get is patients who have central back pain or severe back pain, especially doing something abnormal or something like shifting. Okay, so Bosco, can you look at it and see whether we can see the slides?
The slide is on the way. Loading.
Okay,
I just download your slide only. Just a
no
moment,
problem.
Yeah.
All right. So anyway, so our presentation today is going to be divided to 4 parts. The first part is the common presentations. Second is how common is low back pain, and the third part is what is the treatment that we are doing nowadays. A clinical update about it and what worked. And fourth will be the role of antispasmodics. And we'll have a little Q&A after this, so please feel free to ask me anything regarding low back pain or management that would help you in dispensing and also prescribing the medications. Yeah, so now a little bit about low back pain. Low back pain is the number one most common presentation of musculoskeletal pain in any general practice. It equals to top 10 reasons why a patient comes and sees a general practitioner in the local settings. It equals to about 95% of everyday person will actually present to a doctor once in their lifetime for low back pain. And a fun fact or a fact to be noted that 95% or close to 85 to 95% of the patients usually generally get better, self-resolving within the duration of 1 to 1.5 months after the initial presentation. So it is a multi-billion-dollar business, and also the prescription of antispasmodics appears to be the third most common medication that has been prescribed in the US. We have changing avenue of the usage of antispasmodics where it comes to the US, the UK, and also the European nations where recommendations in the CPG is either pro antispasmodics or do not promote antispasmodics, and we'll go through that. So now currently we'll go to the common complaints that usually the patient complains about. Usually they have an incident of either carrying boxes or doing something abnormal, and these patients usually complain of central back pain or more of leg pain than back pain, or central back pain that goes down, or sciatica that comes down to your legs. So this is the highlight of today's talk, right? So how common is the low back pain? The common types of low back pain presentations, right? How do they present? How's the management options or the treatments that I usually prescribe or we usually prescribe, and the role of antispasmodics. All right. So how common is low back pain? As I said, is the most common orthopedic related musculoskeletal reason of GP practice visits. More than 85% of them will actually have back pain and see a doctor at one stage of their life. Studies have actually shown that a patient who's sitting outside the clinic, actually they believe that everything will be fine if they see the doctor for low back pain. And back pain is not so straightforward. It depends on the etiology, and which we will go through, and management is often individualized. All right, so next slide. So what are the common groups of patients who come and present is usually during the age group of 40 to 60. Most of the cases, about I would say 80% of them confidently can be treated as outpatient and do not need admission, or sometimes in only selective kind of cases they actually need imaging, further imaging on the first initial visit. The most common cause of back pain is acute back pain with no etiological cause. That means there's no actually cause of notable cause of the pain. This is the most common, and most of the cases are treated non-surgically. In the United States, low back pain was responsible for the highest total expenditure in healthcare. In 2016, it was estimated to cost $134,000 billion US dollars in total net worth for dealing with this problem. So this problem is the biggest problem faced, and we need to treat it systematically, individualized, and it needs to have a lot of attention to it. So now this is a nice diagram that we had that I've taken from my colleagues, and it demonstrates the type of pathologies that the patient presents with acute back pain. So if you can note that 85% of them is usually either acute back pain or chronic back pain. Chronic back pain is pain that's been there for more than 6 weeks. Yeah, and the causes in group 3, group 4 are all minority type of cases, or a small exception to the cases. And the more generally is acute back pain and chronic back pain, which we will discuss about the treatments. So what are the different types of presentation? There's only a majority that we could generally take for all patients of back pain. We can actually individualize them to 4 types of back pain. So we'll be using these 4 types of back pain to deal with the management also later. So it's central back pain that's worsened on flexion. That means the flexing the spine. There's also central back pain where it worsens when the patient extends his back, and this is usually due to old age, right, or osteoarthritis of the facet joint. There's leg pain that's worse on back pain. That means this is more of leg pain than actual back pain, and this is characteristic for a slip disc. Back pain with radiculopathy with intermittent leg pain. So this is usually in degenerative disc disease, or older patients would have osteoarthritis of the spine. Yeah. So again, 4 types, and we will go through the individualized management of it. So a lot of patients will come to you and they'll say, is this a slip disc or this is just normal back pain? So the signs and symptoms that a patient is having a slip disc would be the ones that has been put up here. That's unresolving pain. It gets worse, and he has more central pain or more back pain than low back, the leg pain. There's also pain that comes down to the buttock, like sciatica. There's progressive weakening of muscles, bowel and bladder irregularities. So these are signs and symptoms that this is just not normal back pain, and this needs to be investigated. Yeah. Next slide. So another common question is, what is the common cause or risk factors? So there's no common cause, but there's risk factors that tend to, we see these patients more in this kind of risk factors. So one of them is being overweight. Second is contact sports. Third, the most frequent one is lifting objects that weigh more than 25 pounds, right? And also we have patients who have narrow lumbar canals. Usually patients who is occupational related that do see us for back pain is usually physically demanding jobs, frequent stretching, pulling, repetitive jobs, especially drilling. They are more common to get slip disc. All right, next slide. So what can we do, and how do we go about treating it? And as I said, it's 4 types of back pain, and we usually have a treatment specifically for the back pain. So for acute back pain, which is a majority of the cases that we see, right, that we prescribe the medications for acute back pain, this is the 4-part treatment plan that we usually prescribe to the patient. So usually in my first presentation, I will individualize the patient. I will see what is his presentation, and depending on the diagnosis that we come up with after doing an X-ray, right, or after doing imaging that is warranted, I will prescribe the 4-part treatment plan. So the first one is position to relieve pain. So this is an example of the picture over here is an example of one of the positions. It will depend on whether he has a slip disc, or in other cases where they have osteoarthritis of the spine, and that is different kinds of positions to relieve pain. Movement exercises, because they believe after 2 days of rest, the patient should be moving and doing passive range of motions, and also maintaining his quality of life and also motion. Then we come to medications that has been prescribed, which we will go through, and also a very important additional co-analgesia effect is thermotherapy, which we will talk about. All right. So in the pharmacology part of the medications or the medication prescribed, we usually give a combination of medications, which is along the way with the pain pathway gateway theory, and also the WHO pain scale, the pain scale ladder, right? So we give a combination of acetoamines, which is the golden drug or gold drug, and also use of COX-2 inhibitor NSAIDs. Then this is proven to reduce the pain by 10 to 30% in most patients. We use also a muscle relaxant, up to 4 weeks treatment, opioids are generally in Malaysia and in locally it's not recommended, and if also used, is only used as a night dose if the patient has difficulty in sleeping. But we usually do not need to prescribe opioids because we are moving away from opioids because of the opioid overdose and the pandemic that's affecting the overuse and abuse of opioids. So this is the other types of pain relieving techniques that you will be having a lot of relief if the patient's educated and do this. Next slide. This positions actually, the sloppy push-up is the one that actually relieves a lot of pain, especially in slip disc. Next. So this is the proven method in dealing with the pain. Next. This works along with physiotherapy. So a little bit about the pain pathway. As we all know, the pain pathway has five levels, from the sensing of pain to transmission to modulation to perception and the influence of emotion at the end of it. So we use the pain gateway theory, and we use different methods of medications to affect the pain generation and also to numb the nerves. Go ahead, next. So as we all know, there's a pain cycle where it causes pain, it causes muscle spasm and limitation of movement, and this becomes a vicious cycle of pain that will lead to more pain and more pain generation, and also limitation of movement and poorer quality of life. So we intend to use modern techniques and also with the adjunct with the medications used to reduce the spasm and to reduce the pain. Next. So a little bit about slip disc. We have, as we all know, the cervical, thoracic, lumbar, and also the sacral bones. The majority of acute back pain, actually 95% of slip disc actually occurs in the L4, L5, L5S1, or the lower part of the lumbar region. So when the next slide, if we see an axial view, if you see the axial view of the spine, you can see that there is a protrusion on the right hand side. If you can have a look at the two diagrams, the disc is actually in front or anterior to the spinal cord. The spinal cord is posterior, and also the bony part is posterior. As you can see, the first image here has a protrusion or herniation of the disc, and this causes the inflammation or the physical effect of the disc or the nucleus pulposus coming out and touching the peripheral exiting nerve. This is what causes the pain. So it actually generates two ways. One, by releasing the chemotaxic or chemotaxis agents, including prostaglandins and other chemoreceptors that cause the inflammation, and also the physical part of the nucleus pulposus causing inflammation over the nerve. This causes sciatica, and it depends on where does it come out. If it comes out posterior laterally, which is 70% of all slip disc comes out posterior laterally, and 30% centrally, right? So the symptoms would be generated. As we all know, there's different types of pain: acute pain, chronic pain, neuropathic pain, nociceptive pain, and neuropathic inflammatory pain. We'll be focusing on acute pain because this, as I showed you before, was 85% of the presentations that we see. All right, next. So these are the medications we use for low back pain and in general in pain management. But for low back pain, we actually use a combination of all these medications, and we will go through it one by one. So the first one is acetaminophen or paracetamol. Next slide, please. And this is a CNS blocker, and they're able to work as a very good, it's a gold standard drug, which has very least side effects, and it's a CNS blocking mechanism, right? And is used as a co-analgesia effect. Next is the use of NSAIDs. NSAIDs has revolutionized the NSAIDs use has revolutionized the use of painkillers in numbing the CNS, and also it works with reducing the chances, and it is cardioprotective, and also get very few side effects on the gastric also. So it reduces pain. It works with the co-analgesia effect with paracetamol. So the next group of medications that we usually prescribe is, along with this, is muscle relaxants. So muscle relaxant, there's 4 types, and these medications act on the central nervous system as a depressant. It has a sedative and muscular relaxant properties. It's used to reduce the muscle spasm, relieve pain, and also help to improve mobility. So muscle relaxants is actually advocated and can safely be given in patients to up to 4 weeks. So usually our pharmacists and also our general practitioners, we fail to realize we usually give it for a shorter duration of time, but muscle relaxant can safely be given to up to 4 weeks after acute back pain episode. Also, the use of tropical pain relief has really advanced, and we see it being used more and more, and we actually prescribe tropical pain relief for patients with NSAIDs. Tropical pain relief, it acts as a good adjunct, and also with thermotherapy, it also works as a co-analgesic effect. All right, next. So opioids, we discussed about it. It's highly regulated prescription only. We see it not locally or regionally. We see it overseas, especially in the US and in Western countries. We have opioid overdose or overuse, abuse effect. And over here in Malaysia, it's highly regulated. We usually give it only if needed on the night dose. And I usually do not give or do not go into opioids unless it's severe pain. And we use the the WHO pain ladder scale to optimize this. Anticonvulsants is usually for neuropathic pain. We can use it as an adjunct too. Next. So this is your WHO pain relief ladder that we use, and I think everyone is familiar with. All right, next. So a little bit about muscle relaxants. The next slide, please. So muscle relaxants has been, it's the third most common, prescription that's been used, type of medicine that's been prescribed for low back pain, not just in Malaysia, but all around the world. It's one of the main treatments been employed in management of non-specific low back pain. It's a broad class of drugs. It's frequently prescribed in the UK and the US. It has exceeded 1.3 million in the UK, and also 30 million prescriptions of muscle relaxant recorded for low back pain in the US in 2016. So it's ever increasing, and it's a significant amount. So next slide, please. So yeah, exactly. So muscle relaxant, there's 4 types. It can be divided into 4 types. There's antispasmodics. That's example being baclofen. This is another product that we have here with iNova. Non-benzodiazepine antispasmodics, we have a whole load of them, including orphanurine citrate, that is basically Norgesic, and also benzodiazepam group, benzodiazepam, and loosely used in practice is the other kinds like Botox and other kinds of creams that's been used before. That is not so this is an example of the papers, review papers that have been updated. One of them actually explains the different types of antispasmodics, and it's divided into 4 types. And this is actually orphanurine citrate is actually recommended in group 2, non-benzodiazepine antispasmodics, and this is able to give good effect to a patient, or antispasmodic effect without the sedation. And the table 2 also shows us that the use. There is actually been moderate use, and it has review papers, and this is from a meta-analysis that's dated in 2021, I think, 2021 from BMJ, that says that the use has moderate effect on antispasmodics alone. So there's no direct comparison between one antispasmodic and another, but it shows that it's been recommended in acute low back pain. Next slide. So we have two of the medications, as we said, is non-specific benzodiazepam group, and that is Norflex, right? And Norflex is the slide before this, and it's actually baclofen, and it can be given to 100 to 300 mg, right? And this is the second drug, Norgesic. Norgesic has a combination of paracetamol, which is a safe and good drug, with oxycodone citrate at 35 mg. So we usually give this 2 tablets 3 times a day, and can safely be given to up to 1 month. But usually we start it off for 2 weeks first and see whether the patient has any side effects. The side effects is like common other side effects, and they're generally very, very small in amount. All right, next. So we can see here that these are the scores when it compares Norgesic with paracetamol, the pain scores and also the spasm scores. Next. The stiffness scores. Next. So this is the double-blind comparison study, O1, that shows Norgesic with paracetamol. And as you can see, day 10, there's significant changes that is superior than just paracetamol alone. All right, next. So before we go to the next one, there's tropical pain relief. I just want to say in muscle skeleton or muscle relaxant medications, Norgesic appears to be a safe option, and also it combines, it uses the co-analgesic effect where the patient doesn't have to take paracetamol and another drug like oxycodone citrate 35 mg. So it takes 1 tablet and it works both ways, and it can be safely given, and it's also NSAID. So these patients actually do benefit and they do appreciate it rather than getting paracetamol alone. So that is the advantage of Norgesic. And baclofen or Norflex can be given up to 300 mg OD. Yeah. So now we have another adjunct co-analgesic effect, which is Medsal cream, and this can be used as additional tropical NSAID that can be given, and this actually does give co-analgesic effect, and it has very low side effects. We have to note that the eucalyptus oil actually does produce a calm effect and a mental effect also. Next. So what usually my general practitioners, they're worried about what are the medications can be safely given. So I usually tell them that this is the medications that we usually give is paracetamol or acetaminophen, right? With a tramal group or opioid group sparingly at night only if needed. I use NSAIDs for a duration of 10 days, and then I see them back with addition of antispasmodic, usually Norgesic, 2 tablets 3 times a day for about 10 days, and then I'll see them back again, and I'll evaluate their condition and evaluate their pain. And generally, most of my patients do reduce, the pain does reduce more than 30 to 40%, and then I will go accordingly to, by clinical signs and symptoms of whether I need further imaging or I would need urgent intervention. And usually 10 to 15% of them only need surgical intervention at that stage. Usually I see them back about 10 days, and then after that with physiotherapy and with thermotherapy also as an adjunct, with all the medications, usually patients do very well. Okay, next. So usually a lot of pharmacists and a lot of my colleagues like to ask me the role of other adjunct therapies like chiropractic, low back stretching, muscle strengthening, ultrasound, massage, physical therapy. Also, it works wonders and works as an adjunct, but we actually do have evidence that it doesn't work alone in isolation. It works combination with medications. It can safely be done. We also encourage patients to go back to their activities or whatever they enjoy doing, like walking, brisk walking, and as long as you don't carry anything heavy or strain the back, we are okay with that. Physical therapy does help and it improves. Physiotherapy does help. Thermotherapy, that means a warm pack for 10 to 15 minutes also does help. Weight control, use of lumbar brace support also helps. So weight control also, if you are able to reduce the weight or deal with the weight gain, it does have a lot of advantage with low back pain. Next. So I get a lot of doctors coming up and asking me, when should I go to the emergency? When can I see my general practitioner? So I usually say, if you had a fall, trauma, or you're unable to move your legs, or paralysis, or you have bowel bladder abnormalities, I mean, by all you means, go to the emergency. But if you're having mild pain and it kind of resolves when when you try all the other medications, over-the-counter medications like cream, plasters, and sprays and tablets. If they're doing you well, then you can just see a doctor on the weekend, or you can make an appointment as an OPD. Yeah, next. So patient advice, when usually the patient will give me a call on my phone and say, no, doctor, should I come and see you today or should I come in the next few days? So I usually tell them, look, whatever that's causing you the pain, stop that. Or try the over-counter pain relief like creams, plasters, the roll-ons and the sprays. Try that. Try to get some rest, pain relief. Take some bed rest and take some medical leave. Right? Try thermotherapy. Medical leave actually does help in this kind of conditions. Right? Try the creams, patches, and the gels, and then come and see me if the pain is worsened. Now, the take-home message again: the most common type of musculoskeletal pain is actually low back pain or acute back pain. 85% of them are usually acute or chronic back pain. Usually, only 25% of them is chronic. It's the most common musculoskeletal presentation to us. It equals to the antispasmodics or anti-muscle relaxants, actually equal to the third most common medication that's prescribed in low back pain. More than 85% of them will actually pain will actually resolve in 2 to 3 weeks, and they do not need further imaging. The 4-part treatment which I mentioned is now positions to relieve pain, movement exercises, the medications that I went through, and thermotherapy are actually very successful in dealing with back pain. Antispasmodics can be safely given to 1 month. Baclofen is preferred in acute back injuries. Co-analgesia effect of Norgesic, that means acetoamine and antispasmodic, has clear benefits. Addressing the pathology early is important, and early referrals if the red flag signs are there. Yeah? All right, next. So I think if the pain is severe and you're having any neurological symptoms, I think you need to see a doctor and you need to be referred to an orthopedic surgeon. Yeah, next. So now we come to the Q&A session of my talk, and please feel free to do engage in all the platforms of social media and the websites, and also do engage in here and asking me in any way I can assist in treating our patients together. I'd love for you guys to share your experience, and maybe we can co-manage or co-help, see how I can help helping you with dealing with patients' requests or patients dealing with patients' problems. Yeah. So Bosco, if you could moderate the Q&A session. Yeah.
All right. Thank you, Dr. Sanjeev. So we actually have a couple of questions.
Okay.
So the first question is by Ismail. Can we actually give oral and topical NSAID at the same time to the patient?
So that's a common question. Thank you so much, Dr. Ismail. And Mr. Ismail, thank you so much for your question. And it's one of the common questions, I guess. And yes, it has co-analgesic effect. It can be given. And we have reports that topical NSAIDs, actually the absorption equals, if I'm not mistaken, to the last reviews that I've read, equals to different NSAIDs have different penetrations and depends on the doses. But usually around, it's close to only 5 to 10% actually gets to the systemic effect. So local addressing locally, both actually does have its advantages.
Okay. Second question is on warfarin patient. If the patient would like to take the warfarin, paracetamol, and orphanadrine together, is that okay?
So now we come to interactions of medications, and
you want me to take over?
Yes, whenever, yeah. Feel free, Bosco, at any stage.
Like for this one, I actually checked for you. This is by anonymous attendee. Warfarin has no interaction with orphanadrine, but has a little bit interaction with paracetamol. So if you want to use together, then you just monitor the INR. Just monitor closely will do. Okay.
Yeah.
All right.
Yeah. Overall, Bosco, whenever we deal with blood abnormalities or dealing with conditions that dealing with blood thinners in any capacity, whether it is aspirin or Vastarel or any form of anticoagulant, we also have to have it at the back of our mind, any use of NSAID, right? No matter how mild it is, or we may think it's mild, it has a very high potential of bleeding, especially for GI bleeds. So we have to
Okay.
cover. Usually, I'm very the first thing. That's what the first thing I ask my patients, because nowadays our patients are all packaged patients, meaning they have IHD, hypertension, and diabetes, and everyone's on the statin. So we have to actually evaluate what statin they're taking and our risk factors. Yeah, but going through literature, Bosco, right? It's relatively getting very safe with NSAIDs.
Yes, you're right.
Our Yeah, the side effects that we are seeing, it's actually very cardioprotective compared to the COX-1 that we used to have a lot of side effects. So I think we are going the right direction.
Yeah, okay. The next question is, any role of iferison, Myonal, in the management of back pain?
Oh, so Mayonal is epivison, and I looked to it. Yep, it has a similar effect, but direct comparisons between two antispasmodics. I actually went through them, and muscle relaxants too. They have lacking comparative studies, but there is studies that is emerging. And when I do have my hands on them, or I have access to them, I will go through them and I will share it. But at the moment, we don't have direct comparative papers to state one brand over another, or one type of product or non-benzodiazepine compared to the other one. Yeah.
Yes. Another question is, if a patient is having sleep dis and he or she does not recover over 6 months or longer, so what would you do?
So this becomes a clinical presentation of a patient. So generally, patients, 80 to 85% of them actually do recover after 3 to 4 weeks of treatment, right? And the problem is also about the compliance of the patient, cost effectiveness of the medicines, and also how convenient it is. But one thing we need to keep in mind, Bosco, and also all my dear colleagues, is the level of pain or the level of injury to a patient is and is it's really dependent on the degree of the slip disc or the injury to the back. So no two patient is the same. That's one. Two, majority of the patients do well. Three, if the patient has pain more than 4 to 6 weeks, additional imaging has to be done. And depending on the diagnosis of the patient, treatment will be administered. And it also goes back to the four-way treatment, right? So it always depends on the degree of slip disc. Not all slip disc can be treated with oral medications. I have patients who come to me with severe pain in a fetal position, cannot straighten up their back at all, and surgery has to be done. But it depends on the degree of the slip disc. And yes, if it's more than six weeks, whether it's 6 months, 3 months, 1 year, this goes into a very narrow part of the patient's presentations, and that needs to be evaluated and individualized. But usually, coming back to the question, it usually depends on the level of degree of protrusion or the slip disc. Or the slip disc may be big, small, maybe should have been treated, or the compliance was low. And that's what in Malaysia, or in our region, Southeast Asia region, we have a problem with cost effectiveness and getting the right medications at the right time, and also early detection. If they say that if you can administer or see a specialized, you see a doctor within the first 3 days of your presentation, your outcomes will be better if you leave it for 7 days or more. So we have papers also demonstrating that the earlier the patient presents to you, the better the outcome is for the patient.
So
I hope
triple
that
E lah.
helps you. Yeah.
Another question is, in one scenario, would doctor prescribe NSAID over Norgesic? Would you think Norgesic step up if NSAID doesn't work?
Oh, all right. So basically, it's not, I would say it's not comparatively. I say it all works together as a co-analgesic effect. So 1 plus 1 doesn't equal 2. In this case, 1 plus 1 equals 3. And we often we don't use this as individualized treatment. I mean, we don't use it as individualized medication or groups of medication. We combine it with thermotherapy, we combine it with physiotherapy, we combine it with physical therapy, and that's how we gather all the clinical information and we treat the patient accordingly. Whether I would upgrade it or degrade it, I think that's not the way that we look at it.
Multimodal analgesic.
Say again?
Multimodal analgesic, this is called.
Yeah, so a multimodal approach. Yes,
Yes,
that's the way we're looking.
Yeah, there is a question raised. How long would you use a topical or patch? I mean, the safe period, the duration.
Or how long can you use it, or
The topical
in a day?
or patch. Yeah.
So usually it depends on the different topical patches will have different prescription or different amounts of treatment. Some of them are going towards OD now, once a day. Some more, a majority of them is BD, 2 times a day, right? So it depends on your actual product that we use. But I usually use 2 times a day, and I actually use it with thermotherapy. And my patients actually do like the spray and the creams and the whole package together. They like it. And also remember physiotherapy. Also remember physical therapy also really helps. Yeah.
Would you recommend any supplement in musculoskeletal pain cases?
So a supplement, the world of supplements is another topic altogether, and it's gaining a lot of attention. There is 1001 products out there that says that, we described it, is a multi-billion-dollar industry, and supplements is right up there with along with everything else. And the most common supplement that people take is um, glucosamine for wellness, or some form of wellness tablets. At the moment, I went through the literature to look into it, and there's no evidence at all for supplements. So I suggest for us as a group in the medical fraternity, including the pharmacological group of us, I suggest we limit our opinion to it. And if the patient insists on it, then you have to describe to them there's no evidence and they're taking their risks. So please do understand that they have all this have a risk to the liver and to the kidneys, and we don't want to burden them with even more medications that don't work.
Right. There is one interesting question here for children. What medications would you use? Because we understand that Norgesic is not recommended for under 12, right? So if let's say the children comes with musculoskeletal pain, so what would you give? NSAIDs, antispasmodic drugs?
So now the question is under 12 you're talking about? So again, the common acute back pain is usually 40 to 60 years old. The chances of a patient coming under 12 with low back pain, my dear colleagues, is very rare. In my practice, I have not seen a patient under 12 ever come with low back pain or slip disc. But that is also because they're more flexible at that age, and their bones are still developing and the joints are still actively growing, so they can accommodate a lot of these injuries. But I don't think so. It's a very common occurrence, and I don't think so. I would not encourage to use it under 12, right? And if you have to do it, I think it would be used for other things related to spasm, like spasmodic attacks and convulsant, anticonvulsant therapy, and this is all outside our purview of our talk. But overall, under 12, I would be very reserved.
Yeah, very rare also.
Yeah, very rare, very rare. In my practice, I have never seen a person. I think the youngest I had was 16, I think, because he carried something and he had a severe slip disc. And it also, I wanted to discuss, I think I told you all before, is the predisposing factors. So some of our patients actually have a narrow canal of the spine. So, a small protrusion may cause a massive amount of pain and an annular tear. Yeah, go ahead, Bosco.
Because the participants are all pharmacists, so
Yeah.
could you please share with us how do we actually assess the pain level to determine whether the Norgesic alone is sufficient, or do we need to combine with NSAIDs or
So
other things?
this is an excellent question. And so how do I usually assess it is a combination of methods, right? One of it is using the VAS score, where I have a uh, different aspects of different aspects of um, different ways how uh, to present the VAS score. I think I have a few in my clinic, but the simple one of the face, can you grade your pain from 0 to 10? That is a nice way how for me to deal with the pain, and describing them in different languages is a challenge at times, and to get their attention and to get them to give a coordinated answer also is a problem. That's one. VAS score, definitely. Two, I would describe to them off and all, I will do a pain check. That every time I see them, I'll ask them, okay, so how's that treating you and how you doing? And is the pain still there or it's gone somewhere else? Or are you associated with sciatica or something? Another one is this back pain scores, clinical scores. They have the DASH, they have a disability score, where from 0 to 50, and we usually grade them along the way about the main thing focusing on daily activity of life, whether they can get up from their bed without pain, whether they can walk for the normal duration of time to the car, they can drive a significant amount, 10 to 15 minutes. They can drive without pain, and that'll be a better indicator of how to deal with the pain. And when would I restrict my usage of antispasmodics, or maybe let's say this patient I would only give NSAIDs, or I would only give paracetamol, and if his pain is a little bit more, I would give antispasmodics along with it, or I would spare one part and the other part. Actually, we don't practice that way. We practice multimodal, as what we talked before. A multimodal approach, which involves medication is part of it, stretching is part of it, pain relieving is part of it, thermotherapy is part of it, physiotherapy, and adjunct things like chiropractic and massages and stretching. All of this helps. Yeah, coming to the pharmacist aspect of it, they like to find. I mean, they like to ask. Usually, in my presentations, they like to ask me, would you, in any condition, not prescribe them? I generally do prescribe safely antispasmodics because they don't seem to have much side effects comparatively to the ones that we have issue with is usually NSAIDs, and in the elderly, where you see these patients coming in the slightly older age group, where they forget to take the medications, or they're more prone to have a gastric or a cardiac event. So these are the kind of patients that I need to start them on also what do you call it, anti-ulcer medication, or peptic ulcer medication, along with the medications, which can safely be given. But the antispasmodic or muscle relaxant groups actually do not they don't cause that much of gastric events or cardiac events compared to NSAIDs.
Right. There are a few more questions, but I think the time is almost there. I think we will just compile the questions and send to you so that you can answer it later.
I think, Bosco, we can run through it real fast. I can give like 2-minute answers. It's fine. I think it's I'm okay with that. If you all are okay with it, let's go through the questions which is important to you guys, and at least we the best use of.
Yeah, in the best view of time, I think I will just run the pool. There's another 3 pool questions for the participants.
Okay, let's do it. Yeah.
Yes, and I will answer the remaining questions now in my subsequent session.
Okay.
Okay. Yeah, so I will launch the poll now. Can everyone see the poll?
So question number 1 is, which of the following group of medication is not recommended in treating acute back pain?
Wait, I I launch again, just a moment.
Yeah. So let me read it to you guys. The first question is, which of the following group of medications is not recommended for treating back pain? This is a single choice question. So
Yeah,
it's
I
ID
think
NSAIDs,
they are voting now.
muscle relaxant, antidepressants, or anticonvulsants.
Not recommended, which is the wrong one.
Yeah, which is the wrong one.
Yeah, there's one pharmacist, Jimmy, say you need to exit the full screen so that you can see the pop-up window. Thanks. Okay, I will end the poll. Okay, so this is the result. So
yeah. So generally the answer is right, but I think the confusion was antidepressant is benzodiazepine, which is one of the treatments of low back pain. But that's not the sedative part that we wanted to prescribe. So we usually give NSAIDs, muscle relaxant, a combination of acetoamines also along with it. Yeah, anticonvulsants or it can be used in other treatments, but we usually do not. We anticonvulsants. There's certain types of anticonvulsants that don't have that much of general therapy. So the right answer is antidepressants. You're right. Okay, the next question. So question number 2 is, what is the recommended dose for Norgesic? Orfadin citrate 35 and paracetamol 450 mg. Is it 1 tablet OD? Is it 2 tablets BD? Is it 2 tablets TDS or 3 tablets BD?
I think this is pretty straightforward.
Yep. So yeah, coming to that one, just want to remind you that Norflex is actually orfadin citrate 100 mg, and it can be actually given to 300 mg a day, right? Okay, so generally about half of us have answered, and the answer is everyone answered 2 tablets TDS.
Yeah, so the answer is 2 tab TDS. This is a very obvious direct answer.
Yep.
Coming up to third question.
Okay, third question. After this session, I have a better understanding of the role of muscle relaxant in lower back pain management. Strongly agree, agree, neutral, disagree, strongly disagree. So I think we got almost 2/3 of them already answering. And this is excellent. So everyone agrees that they have a better understanding, which is good.
Right. More than half of them I agree. They have a better understanding of muscle relaxant after this.
Yep.
So thank you, Dr. Sanjeev, for this session.
Yep, thank you so much, Bosco, for moderating. And can I just give a few last words or summarize my presentation to you guys? So
Yeah, sure.
basically, when it deals with treatment of low back pain, which is very common, right? A multimodal approach is the best, and I would safely prescribe these medications, especially just making sure that you don't have any cardiac or a gastric issue in the patient. They work in tandem with all the rest of the things, including thermotherapy, physical therapy, physiotherapy, and most of them do very well. So the actual patients that actually come with delayed presentations, basically they need to have a systemic way how to deal with back pain, which is the most common problem. And I think a regulated and a specific treatment for the specific problem, which is most probably in acute back pain, would be acute back pain rather than chronic back pain, will have good outcomes. So it's also important for our patients and pharmacists also to be involved with the anti-opioid use or the opioid reduction use, or in this region at least. In our field in orthopedics, we try to limit the use of opioids because of the overuse and also because of the side effects. And we are getting away with very good outcomes with just using NSAIDs without opioids. Anyway, I'd like to thank you guys, and I would like to encourage you guys to reach out and share your opinions about what I've delivered, and also any questions that I can help with your treatment in all my social media and also my email that will be given at the end of this, and you all can reach out to me and we can have a frank discussion about the use of thermotherapics and also in low back pain treatment. Yeah, thank you so much again, Bosco,
Thanks
and I
again,
will
Dr. Sanjeev.
definitely look out at and answering all the questions that's been given today.
Okay,
Thank you
sure.
so much again.
Have a good weekend. Thank you. All right, so the coming up next talk will be on my side. So I just give you a brief intro. So I'm actually a community pharmacist in Alco Pharmacy, Bukit Sedang, and I've been practicing for the past 10 years. In terms of specialization, I'm actually a minor illness service pharmacist since 2020, CMED pharmacist, dermatological care pharmacist in 2019, accredited pain-wise pharmacist in 2019. So today I'll be bringing you guys through the advantages of fixed-dose combination therapies. So just a little bit of disclaimer. The information and all the materials shared later is being provided as information service and as professional courtesy. So it's not intended for any medical advice, diagnosis, treatment, and only for sharing and educational purpose. All the views and opinions expressed here are from the speakers and do not necessarily reflect the positions of iNova. So first and foremost, let us go into the definition and what is pain. So pain is actually an unpleasant sensory and emotional experience associated to a real or sometimes a potential tissue damage. According to Malaysia's CPJ, pain is actually the 5th vital sign, which means that it should be automatic to be taken when patient admitted, just like you take the blood pressure, respiratory rate, pulse rate, and also the temperature. When you have pain, it will actually elicit a neuroendocrine stress response and release the cortisol and catecholamine, which in turn increase your BP, your blood pressure, your heart rate, your pulse rate, and also your respiratory rate. This is the slide of explaining the pain spasm cycle, where actually when you have stress respond to pain, it will affect multiple organ systems, including the urinary tract, gastrointestinal, and also your musculoskeletal, your muscle system. So in this cycle of pain, it actually illustrates the physiology tissue response during you're having the acute tissue injury and inflammation. So as you can see, the cycle of pain following the tissue injury, the muscle actually maintain high level of resting tension. So they are used to protect and prevent the motion. Because muscle continuously guard the region, and hence the circulation to the affected muscle tissue is affected, and it will trigger the cycle of swelling impact the circulation and hence will cause muscle cramps and also muscle soreness. These are the 4 processes of nociception, which I mentioned earlier as well. So this slide actually tell you about there are 4 ways of transduct the impulse of the pain during transduction, transmission, how you perceive the pain, and also you modulate the pain. So all this pathway we can actually target and put in medication. Okay, so when you give medication, we can target a different pathway. That's what we call multimodal analgesics, so that it works synergistically. So in terms of pain assessment, actually it was being asked by one of the pharmacists just now, what you should ask. So these are the questions that you can ask in the pharmacy. There are many mnemonics can be used to obtain the pain history, such as PQRSTU, case tape, and also Socrates. I'll focus on Socrates because this gives a more detailed history taking. The mnemonics S means site. You can ask the patient when they first come in, where is the pain or the maximum site of the pain? When did the pain started? Is it a sudden pain, gradual pain? Is the pain progressive or getting lesser, a regressive pain? What is the characteristics of the pain? Is it an aging pain, stabbing or throbbing pain? Does it radiate to other ways, other place? Because we need to identify the red flags. Association, any other sign and symptoms associated with it, such as nausea, does it disturb your sleep? In terms of time course, does the pain follow any pattern, such as the duration, how long already? Is it less than 3 months or more than 3 months? Any exacerbating or relieving factors? What makes your pain feel better or make it worse? Or have you tried anything? In terms of severity, you can also ask the patient how bad is the pain? Can you rate based on the scale 1 to 10? So this is a combination of rating scale which is been using in the Ministry of Health. Patient actually can slide the scale from 0 to 10. 0 is no pain, 10 is the worst pain. Okay. Another one is the facial scale. This is the facial scale, MOH pain scale. Patient can also tell you the facial expression if they cannot rate themselves. Okay, going into types of pain. So there are actually 3 types of pain: acute pain, which is less than 3 months, chronic pain, which is more than 3 months, and you are having chronic pain, and sometimes it's acute chronic pain. Okay, the causes can be cancer pain or non-cancer pain, and the mechanism can be due to physiological, such as nociceptive pain, or due to pathological, neuropathic pain. For acute pain, usually is sudden onset, short duration, and it can resolve when the tissue heals, while for chronic pain, it will persist despite the tissue heals. Okay, so acute pain is less than 3 months, chronic pain more than 3 months. For acute pain, there is warning sign of potential tissue damage, while chronic pain, there is no warning sign. It could be a false alarm. And acute pain, the severity actually correlates with the amount of damage, while chronic pain, there might be good days or bad days. Okay, sometimes you have pain, sometimes you don't have pain. The pain will just persist. While for acute pain, it is CNS intact, and chronic pain, the CNS, the central nervous system may be dysfunctional, such as neuropathic pain. Okay, acute pain, when you unrelieved, it might cause anxiety or sleeplessness, and you can improve when the pain is relieved, while for chronic pain is often associated with depression, anger, fear, and also social withdrawal. The common causes of acute pain include fractures, MI, inflammations. These are non-pathological usually. For chronic pain, there are more disease types such as long headache, low back pain, cancer pain, abdominal pain, and neuropathic pain. They are usually persist more than 3 months. When you have more pain, you will have more spasm. So all this acute pain can lead to reflex vasoconstriction, lower mobility, and impact your muscle metabolism, and hence causing a buildup of waste product and increased acidity, which in turn lead to muscle spasm. That's why we are saying more pain, then you have more spasm. There are two types of pain: nociceptive pain, pain resulting from the activity, damage due to stimuli, example due to surgical pain or spot injury. For the another types, is neuropathic pain. It could due to somatosensory system and could originate from peripheral or central. Peripheral due to damaged nerve, central due to spinal cord injury. In terms of pain management, we can actually manage the patient based on RAT approach. R means recognize. You can see if the patient is having pain based on the look and what is his or her mobility level. Is he or she having sweating at the moment she asks you? Does other people know the patient has pain? Other healthcare workers, family members? And then we can assess the pain based on the Socrates model just now and treat the patient based on non-pharmacological treatment first, then only consider pharmacological treatment. For non-pharmacological treatment, we can actually go with physiotherapy approach, such as heat pack or cold pack, using TENS machine, or through CBT, cognitive behavioral therapy, counseling, or complementary medicine like acupuncture, and refer to the occupational therapies. For pharmacological treatment, we can always refer to the pain ladder, and there is non-opioid medications and opioids you can choose from. Besides all the opioids and non-opioids medications, there are also called analgesics, called antispasmodics, muscle relaxant, and also anxiolytics. We'll be focusing on muscle relaxants today. Antispastic and antispasmodic. Antispasmodics are directly affecting the spinal cord and skeletal muscle, with the aim of improving the muscle. Examples include baclofen and diazepam. Antispasmodic include reduce the muscle spasm via the central nervous system. The example would be the orphanadrine. Orphanadrine citrate, how it works. It actually works centrally and act within higher level of central nervous system. It interferes with reflex pathway for pain and skeletal muscle contraction. And the pain caused by muscle spasm actually responds very well when you give orphanadrine. It also exhibits the analgesic effect besides of its muscle relaxing properties. So it actually helps to stop the vicious cycle of the pain spasm by reducing the muscle contraction, reduce the pain, reduce the muscle spasm, and restore the function. Orphanadrine citrate can actually interrupt the skeletal muscle contraction and relieve the pain in 30 minutes. These are the multimodal approaches which we mentioned just now. We will recommend patients to use exercise therapy, especially for low back pain patient. If you're obese, you're advised to cut down your body weight. When you cut down your body weight, you can actually reduce the medication also. And in terms of psychosocial intervention, there is moderate evidence. For corticosteroid injection, limited evidence. And if you want to give oral or topical analgesics, there are also limited evidence, but you can combine with muscle relaxant. There are strong evidence. For physical remedies, non-pharmacological therapies, you can be given ice pack or hot pack. These are limited evidence. What are the goals of multimodal approach in pain management? It actually involves combination 2 or more pharmacological drugs to target different aspects of pain pathway. So at the same time, it will lessen the amount of drug, the strength of the drug needed to achieve the desired effect and reduce the risk of adverse effects. It also helps to reduce the opioid use, misuse, and patient dependence. So FDC, the fixed dose combination, are commonly used, and they actually give a better effect and longer duration of action. So these are the journal which showing that a research that comparing the Norgesic, orphanadrine, paracetamol over the paracetamol alone. So it shows that actually it has a superior efficacy than you just give paracetamol. So there's no doubt that the combination is more efficacious than the placebo. Another research also showing that when we measure the parameters, pain, spasm, and impact activity, it shows a significant quicker recovery when you use the combination product. This is a double-blind comparison when you compare orphanadrine citrate and paracetamol with paracetamol alone. So Norgesic actually offers effective relief from pain and stiffness. The red one is Norgesic. The blue one is the paracetamol. So as a conclusion, the combination of orphanadrine and paracetamol actually provide an effective relief of pain when you associate with muscle spasm. The combination pill actually found to be clinically superior than each of the components used alone. So it's useful in helping to break the pain cycle resulting from minor trauma or injury. And orphanadrine is definitely an alternative treatment for muscle spasm without the risk associated like NSAIDs and codeine. When you're having painful musculoskeletal condition, they're actually easily recognizable. And sometimes they are very much self-limiting and suitable for short-term treatment under the supervision of pharmacists. That's all from me. If you have any questions, just drop your questions in the Q&A chat box. Okay, so I will go through the questions you have not answered just now. There's one question being asked by anonymous attendees where can breastfeeding and lactation mother take orphanadrine and PCN? For information, pregnancy and lactated mother is not recommended because there's no study to prove that so far. So if apply the analgesic patch, is it suitable to take any antispasmodic medication at the same time while on patch? Depends. If you're having muscle spasm, you can give Norgesic. And yes, there's one question being asked in the chat box. Norgesic is poison B. Yes, you're right. Poison B. You can refer to the doctor before dispensing. We do have what do you call it? Online doctor counseling service. If you're subscribing to, such as Talk to Us, Talk to You, there are various ways that you can access to the online doctor if you want to help your patient. Will orphanadrine for long-term use cause addictive effect and reduce effectiveness? Will you recommend it for regular use? For information, it would not cause any addictive effect, but usually we recommend only for short-term use. At what point does the patient consider surgery and how safe it is dealing with the spine? I suppose this is referring to the doctor. If you encounter any reflex symptoms, you need to refer to the doctor. Can we take Norgesic together with the magnesium supplement? Regarding to the supplement, you can actually recommend magnesium. I mean, as a community pharmacist, I do recommend magnesium 200 mg, usually on OD to BD, depending on the spasm level. And in the meantime, you can also recommend ginkgo or turmeric if they need it. Okay, I think that's almost there, the questions. Do we advise patient to take Norgesic together with NSAIDs or take at different time? You can give Norgesic to combine with the NSAIDs, but depending on the situations, if you feel the patient is having inflammation, then you can give it multimodal analgesics. But usually we will try to give Norgesic first if you are having muscle spasm. Unless it's very long already, then you might add on with NSAIDs. All the pain medication can be suitable for pregnancy and breastfeeding women. You may need to check for this because the pain medication you refer here might be referring to NSAIDs or paracetamol. For paracetamol, it is safe. For NSAID, you may need to check which trimester the patient is on. Okay, I think I almost covered all. For those that I missed out, the SwipeRx team. Okay, another question is coming up. Is Norgesic causing drowsy significantly? Oh, okay. For information, the orphanadrine actually, the molecule mimics diphenhydramine. That's why they do have a H1 receptor blocker. So it will cause drowsy effect. Not to say significantly, a bit sedative lah. A bit sedative when you're trying, when you dispense Norgesic, you need to counsel the patient on the sedative effect. Okay. For fibromyalgia, how do we manage the pain suffer from fibromyalgia? This one, I suppose you need to refer to the doctor. It's our capability to do it. But usually I will ask the patient, we will manage based on the symptoms. What is the drug of choice for pain and reliever medication linked to ADHD? For pregnant lady, usually we will give paracetamol. I'm not sure where you find the study that paracetamol will link to ADHD and autism. So far, it has not been raised up that frequent. Or can you provide us or any link or research study that you show PCM linked to ADHD and autism? Because it's pretty safe actually. And many FDC do combine with, to take paracetamol as the base. Another question is, what are the advantages of fixed dose combination over taking individual medications? As I mentioned earlier, the fixed dose combination actually provides a synergistic effect and reduce the side effects of the individual drugs. When you give FDC, the fixed dose combination, you can actually reduce the dose of single component, and also it provides a synergistic effect. Besides Norgesic, there are other FDC available in the market. So for your information, there are also other FDC such as Ultracert that using paracetamol as the base. Contraindications for Norgesic, any kind of patient can't take it. This one so far is pretty safe, but because it's a combination medication, so for elderly, you need to be careful because most of them are taking quite a lot of medications. There might be polypharmacy cases. So when you want to give Norgesic, you need to go through the medications, especially elderly, you have to be careful. What are the potential risks and side effects of FDC? For this G6PD patient, there being one question being raised: is Norgesic safe to be used in G6PD patients? So for G6PD patient, need to be careful is if you are allergic to paracetamol, high dose vitamin C or fava beans. Other than that, should be very safe. But if you take paracetamol before, then should be okay. Orphanadrine so far has not much interaction. Can breastfeeding mother take Norgesic? No. Pregnancy and breastfeeding, we don't have data to prove it first. So we will avoid Norgesic at the moment. This one, another question raised by Yong Xing Rong. As we mentioned, elderly need to be careful when taking Norgesic. Can give an example of the units or which drug have polypharmacy issue. For patients, they are on many medications, especially elderly. Some patients, they might need to watch out because most of the elderly, they like to take Panadol, right? So since the Norgesic will be taking paracetamol as the base, so if you want to give Norgesic, perhaps you need to go through the medications to see whether there is double, paracetamol in the regimen or not. Other than that, it should be very safe. Yes, there's another question raised by Jaswin. In terms of patient compliance, yeah, it do help to improve patient compliance because you don't need to take the 2 pills, just need to take 1, okay? So it will definitely help the patients in terms of pain, especially cancer pain patients, because they're having a lot of medications. So this FDC will help them to cut down their pill burdens. All right, I'll take another question in another 2 minutes time. Then we will launch the poll. For end-stage patient, Norgesic is paracetamol as base, so I don't think there's much concern on kidney failure patient. Unless they are liver failure problem, then you need to be careful. Another question by Jaswin: what are your key considerations in choosing best muscle relaxant and analgesics combination for back pain? Depending on the conditions. So far the study has not proven one muscle relaxant is superior than another. So usually we will see the conditions, only we will decide now. Can we take Norgesic for long term? Usually we will recommend for short term, not for long term. If it is long term, then you may need to review the condition and check the condition again. Okay, I think I almost cover all the questions. All right, I will launch the poll now if there is no more questions. So another one question in general, can you confirm that Norgesic is safe and well tolerated? Can you share any issues you encountered on giving Norgesic to patients and how do you manage those? Usually Norgesic is generally very well tolerated and safe. And when we dispense Norgesic, usually we will only counsel on the sedative effect. And be careful if you are driving, and you may need to ask the patients if they prefer drowsy or non-drowsy medications. So other than that, it shouldn't be any issue. Can customers take Norgesic along with patch like Ketotalk? Yes, you can, no problem, because they are different medication. Is low back pain one of the indication for Norgesic? What other indication? Is indicated actually for muscle spasm actually. Yeah, musculoskeletal problem. Often can cause dependent. I have seen patients keep coming back for Norgesic. Perhaps you need to do a counseling for a patient. You need to understand further why the patient keep coming back. Maybe it's due to other problem. Perhaps you need to intervene. Is sedative effect more of beneficial to the patient since they are in pain and find it hard to sleep, or is it a risk? Depending on the patient. So if they find it is helpful for them, especially elderly, then they can take Norgesic. But if they want to work, they want to study, so it might not be suitable. For a patient previously on Norgesic, how long should the patient wait again before taking Norgesic again? Well, actually depends on the situation. If you have completed a Norgesic for 1 week or 2 weeks and the pain keep coming back, perhaps you need to assess the pain again, see what are the conditions. Or is it Norgesic alone is not sufficient? You need to add on with other medications or other non-pharmacological management. How about Norflex? Is it safe? Yes, it is safe, but I don't think it is easily available because I don't think usually pharmacy will keep Norflex. Any more questions? Aside from back pain, what other indications that you find Norgesic useful? Usually we will give Norgesic for muscle spasm. We will dispense most of the cases for muscle spasm, low back pain. Okay, so I think I've covered all the questions. I will launch the poll. Okay, can someone who are menstrual pain take Norgesic? Yes, you are having muscle cramp. Yes, the answer is yes. Okay. All right. I will launch the poll now. Okay, can everyone see the poll? The first question is on the combination pill Norgesic. Is it considered clinically superior to using each of its component alone? Yeah, I can see everyone voting already. All right, half have voted. I see another question pop up again. In your experience for patients with low back pain, do you give Norgesic first or N6 or combination right away? Depending on the situations. For short term, if the patient's the pain is not so long, we can consider Norgesic first. But if it's like too long, and there are inflammation, there is pain, inflammation for quite some time, perhaps you need to give N6. Can someone on tranexamic acid suitable to take Norgesic at the same time? Perhaps you need to ask why the patient need to on tranexamic acid, because tranexamic acid usually is on short term, 3 days or 5 days only. It will not on long term unless the patient is having underlying morbidities. Okay. All right, I end the poll. Okay, so for information, Norgesic actually exhibit pharmacological synergistic effect. The answer is C. Okay, so second question. Oh, very fast this time. We will wait for another 30 seconds. All right. 10 seconds. Okay, I will end the poll. So for your information, fixed dose combination FDC, they are commonly used for multimodal analgesic because they give better results and actually they exhibit a longer duration of action than the single component. Okay. All right. Last question. Wait. Can you see question 3? Oh, okay. Oh, I see there is another question. Since Norgesic is a muscle relaxant, can patient with bladder obstruction or urinary retention take it? You have to see the situations. Because Norgesic, they do have these kind of side effects, right? So if the bladder obstruction and urinary retention is very serious, then you might need to consider alternative. Do not give when you are unsure. Okay. Okay. For patient experiencing low back pain due to kidney stone, I see the question keep coming in, non-stop. Is Norgesic helping? Depending if it's causing muscle spasm, then it will help lah. But if it's not due to muscle spasm, then Norgesic wouldn't do the job. Another question come up again, is Norgesic safe for heart failure patient? The base is paracetamol and norepinephrine. I don't see a contraindications for heart failure patient. Yeah. Okay, another 30 seconds. All right, I will end the poll. Okay, so more than half actually agree, have a better understanding of the advantages that Norgesic as a fixed dose therapy. Okay, all right. So I guess that's the end of the session. I hope everyone is clear with the FDC. So we thank you, iNova, and also SwipeRx for this wonderful session and platform so that we can learn all this together. So if you do have any more questions, feel free to ask us. So for the certificates, now please expect the SwipeRx team to email you within 7 to 10 working days, as they will need some time to consolidate the report. Thank you for your understanding. So for those pharmacists that log in, log out, and then I see some of them do type in the chat box asking whether they will get the certificate. Don't worry, the team is catching your attendance. So your certificate is unaffected actually. Okay. All right. So if you are on the SwipeRx platform, you registered already, do remember to access the iNova pharmaceutical CBD modules. They will give you extra CBD points. They're also ready in it. So you just click in and go into the modules. And on the right-hand side, there's a launching of a pre-recorded webinar. You do attend the session. It was on the last week by Miss Gina. So this is a pre-recorded webinar. If you have missed it, you can actually will lead the pre-recorded session on the coming week. Okay. So thank you for your time and thank you for joining us this time. Hope you have a better understanding on fixed dose combination. So have a good Sunday.